Now we move on to the next section about nutrition and nutrition disorders in children. We'll start with the normal feeding, which will be about breastfeeding. Okay, we all know that breastfeeding is an invaluable source of nutrition for all small babies. And when we talk about the nutritional value of breast milk, it is 67 kilocalories per 100 ml. Okay, and when you study about breast milk, we always compare it with the cow milk and try to tell the differences between the two. Okay, so in comparison with the cow milk, breast milk has more carbohydrate. Basically, the carbohydrate we are talking about is a lactose. So more lactose in the breast milk compared to the cow milk. Then when we talk about proteins, it is less protein. In fact, it is 3 times less protein. However, the point to be noted is that the breast milk protein is easily digestible when compared to the cow milk protein. This is an important point to be noted. And then we talk about the fat. It is almost equal amount of fat. However, when we talk about breast milk, it is rich in PYTs, which is nothing but polyunsaturated fatty acid. Okay, so the amount of fat in the breast milk and cow milk is almost the same, but breast milk is rich in polyunsaturated fatty acids. Now, this is one aspect which is related to nutrition. Now, breast milk also has other properties which includes immunological properties, starting from the first found milk itself, which is what we call colostrum. And this colostrum is rich in immunoglobulin A, IgA. This is a very important question by itself, asked many times in your exam, which is nothing but an protective antibody against many infections. Okay, right. Now, breast milk also contains other important substances which can be remembered by a mnemonic called PLAB mnemonic, P for para-aminobenzoic acid. Actually, there are low levels of para-aminobenzoic acid in the breast milk, which is protective for malaria infection. It gives protection to malaria infection. Then L for lactoferrin, which is an antibacterial substance, and it is very important against the growth of E. coli. Then A is the IgA, which I have already told you. Then last one is B for bifidus factor, which is again protective for E. coli infection. This is what we can remember the immunological substance in the breast milk as PLAB. That's a mnemonic to remember the immunological substance in the breast milk. Then the other effect of breast milk is related to brain growth. You should know some of the important brain growth promoting substances in the breast milk, which includes number 1, whey protein, which is the predominant type of protein in the breast milk. Number 2, certain amino acids in the breast milk, namely the taurine and cysteine. Third is the PUFAs, polyunsaturated fatty acid. The best example of that is DHA, which is docosahexaenoic acid. All these substances are present in the breast milk and they promote brain growth. Okay, right. Now coming to some deficiencies in the breast milk, which is related to micronutrient deficiencies. We'll start with the vitamin deficiencies. The most important vitamin deficiency is vitamin K. This is an important question. So that's why for all babies as a prophylaxis, we give injection vitamin K at the time of birth. Then the next important vitamin deficiency is vitamin D, which is again supplemented as oral drops to all breastfeeding babies. Okay, right. So these two are important deficiencies in the breast milk. Now, what are the other nutrient deficiencies? It is mainly iron deficiency. Okay. Please remember that iron is deficient, but it is generally not given as a supplement because a baby, I'm talking about a term baby has lot of iron stores. Now, this iron stores in the term baby will protect itself from developing iron deficiency anemia. So that's why you don't need to routinely give iron or supplement iron to all breastfeeding babies. However, in which group of babies they require supplementation, it is for the other group. What is that? Yes, preterm or low birth weight babies, they require iron supplements. Okay, so iron generally is not given as a supplement except in preterm low birth weight babies where we have to give iron supplement simply because these babies have very less iron stores. Simple reason. Okay, so this is something related to deficiencies in the breast milk. Next, moving on to storage aspects of the breast milk. In a room temperature, breast milk can be stored up to 6 to 8 hours. And if it is kept in a refrigerator, up to 24 hours it can be kept. And if it is kept in a freezer, it can be kept up to 3 months also. Okay, right. So finally is about mode of feeding in preterm. Remember, in preterm babies, we may not always advise a direct breastfeeding. So some modifications are required in the mode of feeding in preterm. If the baby is less than 28 weeks of gestation, born at less than 28 weeks of gestation, or in a hemodynamically unstable baby, what is recommended is TPN, which is total parenteral nutrition, meaning you need not give any form of milk to the baby. It has to be parenteral nutrition with IV fluids. Okay, right. And if the baby is between 28 to 32 weeks of gestation, here breastfeeding can be started, but not direct breastfeeding. The mother has to express the breast milk and give the feeding through NGT, that is nasogastric tube, or OGT, orogastric tube feeds is recommended. Okay. And after 32 weeks, that is 32 to 34 weeks of gestation, it is recommended to give the feeding by Paladai or Katori spoon. Katori spoon. And after 34 weeks of gestation, you can start direct breastfeeds. Okay, right. Next, we have to know about some special situations and breastfeeding. One example of that will be HIV and breastfeeding. Okay, remember when we talk about HIV at an international level or in the developed country, we say that it is a absolute contraindication. However, in India, it is a relative contraindication, meaning if the mother or the family is not affordable for the formula milk, that is the other type of feed, then she can give exclusive breastfeeds for the first 6 months. So it's only a relative contraindication. And please remember, after 6 months, okay, complementary feeding has to be started, of course. However, breastfeeding should not be abruptly stopped. It should be a gradual cessation of breastfeeding, meaning after 6 months, slowly, you decrease the amount of feed and increase the amount of complementary feeds in the child. Okay, right. And always remember, when the baby is breastfeeding from a HIV positive mother, the baby should take prophylaxis. The important drugs recommended for prophylaxis are: one is antiretroviral drug itself. What is that? Yes, it is nevirapine prophylaxis, which is recommended since birth itself. And one more is cotrimoxazole prophylaxis, which has to be start at 4 to 6 weeks after birth, and it should be continued till 6 weeks after cessation of breastfeeding. Okay, these are the recommendations when we have a HIV positive mother who is feeding her child. Okay, right. Now we move on to the next section of nutrition, will be about nutritional disorders in children, starting with two important types of PEM, or what we call protein energy malnutrition. Okay, right. These are the two names we have. One is kwashiorkor, another one is marasmus. There are good number of differences between the two conditions, and which is commonly asked in your exams also. So let us start with the discussion of differences between kwashiorkor and marasmus. Now, talking about the age at onset, kwashiorkor is after the age of 1 year. Marasmus is early onset. Within the age of 1 year itself, it's going to start. Then about the nutrient deficiency, remember it's general deficiency of all the nutrients, but we talk about predominant nutrient deficiency. In kwashiorkor, it is predominantly protein deficiency, and marasmus, it's more of calorie deficiency. And in kwashiorkor, protein deficiency is the main reason why the child develops lot of edema. I'm putting 3+, meaning it is fully edematous child in case of Kwashiorkor, and it is nothing but generalized edema or called as the anasarca. Whereas marasmic child will not have an edema. It's very clearly obvious in this picture itself, where you can see a fully bloated child in Kwashiorkor. Especially you can see the abdominal distension very clearly in Kwashiorkor, whereas edema is not a feature of marasmus. Okay. Then talking about the appearance of these two children, Kwashiorkor child are usually dull or having a lethargic appearance, whereas children with marasmus are usually having an alert appearance. They are usually having an alert appearance. Then talking about the appetite, okay, it's a decreased appetite in case of Kwashiorkor, whereas it's a good appetite in case of marasmus, or I'm going to write vigorous appetite in case of marasmus. Okay, so out of the two condition, which of these is a better condition? Obviously it's marasmus, so the prognosis is good for marasmus, whereas it's a poor prognosis in case of Kwashiorkor, meaning they don't have a good appetite, they don't respond usually to the treatment, and they also show a very late response also. That is why out of these two conditions, the better condition is marasmus. Okay. Now the hallmark feature of Kwashiorkor, I have already told you, is edema. Whereas when we talk about the hallmark feature of marasmus, it is evidence of wasting. It is evidence of wasting. And can you see the characteristic evidence of wasting in this particular child? In the face, there will be lot of skin wrinkles noted. Lot of skin wrinkles noted. Something like a old man like appearance. Next, in the chest area, you can see the outline of the ribs. This is what is called as a skin and bone appearance. And in the other parts of the body, like here, you can see lot of loose skin folds. These are the characteristic manifestation which tells you that a child with a marasmus has significant wasting or a visible wasting. So that's about the differences between Kwashiorkor and marasmus. Then you should know there are some additional features in Kwashiorkor. One feature would be in the form of swollen liver due to fatty liver. Fatty liver. Second one, if you look at the hair of these children with Kwashiorkor, they have alternate white and black areas, which is what we call it as a flag sign in the hair. Third one is what you are seeing in the picture, where you can see some brown spots in the skin area, which is what is called flaky paint dermatosis. Flaky paint dermatosis, which is a finding in the skin. So these are additional findings of Kwashiorkor which you should make a note of. Okay, right. Then we move on to the next section in malnutrition, which will be related to WHO's classification of malnutrition. WHO classifies malnutrition into moderate and severe categories. Please remember, there is no term called mild category. That is on the one side. And the other side, based on the duration, it is dividing into acute and chronic, as you can see that. Okay, right. And one more feature is edema, which I'll come to shortly. Okay, now acute malnutrition is a condition characterized by weight loss, and we use the word wasting for this condition. And the chart which will help us to categorize this acute malnutrition is weight for height chart. This should be remembered. Whereas for chronic malnutrition, it is more of a height problem, and we call this as stunting. Okay, and the chart which will help us in this category will be H by A, or the height for A chart. Okay, right. So now you're clear about what is acute and chronic. Next, you should know what is moderate and severe. See, always it is based on the WHO charts. Okay, this categorization is based on the WHO chart. We have already seen the WHO chart, right? And I told you the lower cutoff is -2 standard deviation in terms of standard deviation. Now, to make a distinction between moderate and severe, okay, you just remember like this. Whenever the value is between -2 to -3 SD, it is called moderate malnutrition, which will be the same for acute and chronic. -2 to -3 SD is called moderate malnutrition. Whenever the value is below -3 standard deviation, it's called severe malnutrition. Correct? Okay, right. And one more last thing is the edema. Okay, and if edema is present, it is categorized under severe malnutrition. Okay, so this will be the WHO's classification of malnutrition. Okay, now next we move on to something called as severe acute malnutrition, an important condition to be remembered. Some points have been already asked so many times in your exams. First is relation to the definition of SAM. Okay, right. Acute means it is the weight which is affected. Severe means the value is below -3 standard deviation. So what will I write? Weight for height below -3 standard deviation is the first thing. You have already seen that in the table, the preceding table, that edema is a feature of severe malnutrition. So I am going to write here bilateral pedal edema is the second feature of this severe acute malnutrition. And third important is mid-arm circumference less than 11.5 centimeter. I have already told that with relation to the Shaki's tape. Right. Now, out of these three manifestations, any one itself, if it is present, then you can label the child as suffering from acute severe malnutrition or SAM case. Okay, right. This is the criteria for defining a child with severe acute malnutrition. Then we move on to assessment and treatment of severe acute malnutrition. Remember, in any child presenting with SAM, you have to ask three things. One is about the appetite. Second, you have to assess whether there are any complications. Third, you have to look for edema. If the child is having a good appetite, no complication and minimal edema, it means that treatment can be done at a home setup itself or a community healthcare level itself. You can treat. If the answer is yes, child is having good appetite, no complication and no or minimal edema, then you can treat the child at home. If the answer to any of these questions is no, that means child is not having a good appetite or having complication or having massive edema, then you have to hospitalize the child and then you have to follow the treatment. Okay, right. Going forward, I am going to tell you about the hospitalization management guidelines for a child with SAM. And it follows something called as a 10 steps of treatment. Okay, and it occurs in two phases. The phase 1 is the stabilization phase, where our focus is mainly about complications. Phase 1 is stabilization phase, which is all about complication. Then we have phase 2, which is about rehabilitation. I'm talking about nutritional rehabilitation. Okay, nutritional rehabilitation. Okay, and now I have given all the steps in this particular diagram. Now what I want you to focus on is something called as a complications in SAM, which are the management in the first or the stabilization stage. Okay, right. And the complications are remembered by this very famous mnemonic called shielded mnemonic. S for the sugars, which refers to a sugar value of less than 54 milligram per deciliter. Glucose values are less than 54 milligram per deciliter. H for hypothermia refers to an auxiliary temperature of less than 35 degrees centigrade. And I for infection, the common group of infection which you get in SAM is gram-negative enterobacteriaceae infection. Okay. Then EL for electrolyte imbalances. Electrolyte imbalances commonly include hypokalemia, hypomagnesemia, as well as high sodium. These are the important electrolyte disturbances. Then we have dehydration as a complication which can occur, and D is for the deficiencies, which includes all the micronutrient deficiency. And here an important point needs to be remembered. What is that? Which micronutrient should not be given in the first week of treatment in SAM? I'll take you back to the table where you can see this particular part. Micronutrients, can you see in the first week of treatment, no iron is written. This is important. Okay, so iron should not be given in the first week of treatment in SAM. What is the reason why iron is not given? Simply because in the first week of treatment, there is a decreased absorption of the iron, and this unabsorbed iron will lead to some problems, like it will promote the bacterial growth. It will promote the bacterial growth. I'm talking about pathogenic bacterial growth, number one. Number two, it will also cause free radical damage to the intestine. Because of these two reasons only, iron should not be given in the first week of treatment in SAM. This has to be remembered. Okay. Now, finally, coming to criteria for discharge in a child with SAM, I'm talking about hospital discharge criteria. First, there should be no edema for at least 2 weeks. Child can be prepared for discharge. Next is the weight criteria, wherein we say weight for height reaches -2 standard deviation, meaning at the time of admission it was below -3 standard deviation, but now it has come up to -2 standard deviation. Child can be prepared for discharge. And third is mid-arm circumference reaches at least 12.5 centimeters. If all these are satisfied, then I can discharge the child from the hospital. So these are the salient points which you should remember regarding management of SAM. Now we move on to the discussion of individual micronutrient deficiencies, starting with the section of rickets. Such a common and a basic topic, most of you know about this, and one special section I wanted to highlight towards the end. Okay, rickets is a condition of vitamin D deficiency, correct? And what is a basic problem due to the vitamin D deficiency? Calcium and phosphate will not be deposited in the bone. That is what is meaning of decreased mineralization. Calcium and phosphate is not deposited in the bone. Okay, and which is the site of the bone which is affected? It is the metaphysis, where we have the growth plate. That is the site affected in case of rickets. Okay, and because of decreased mineralization, the bone will lose its strength, and this results in deformities in case of rickets. Deformities in case of rickets. Okay, can you see the number one finding denoted by 1? What is that? It is at the costochondral junction there is widening. Okay, there is widening, and this is what we call it as a rosary appearance. It's nothing but small beaded appearance like this, which are at the costochondral junction, called as a rosary appearance. It's also called string of beads appearance, also called as string of beads appearance. Okay, that is number one. Number two, which is at the lower border of the rib cage. Can you see that lower border of the rib cage, where you can see a depression, and this depression is created by the pull of diaphragm called as the Harrison sulcus. Okay, so this is due to the pull of diaphragm. That's the second important feature of rickets in the chest. Then we move on to the next set of features, which is related to the findings in the limbs. One is very characteristic. What is that? Wrist widening. Wrist widening. The next set of findings goes like this. What is the second picture depicting? Yes, it is a bowing of the legs, which is also called as a genu varus. And the third finding, where you have a lateral deviation of the lower limbs, which is called as a genu valgus. It's also called as a knock knees. Also called as a knock knees. These are some characteristic deformities in rickets, which you should make a note of. And how do we generally make a diagnosis of rickets? It is with the help of X-ray. So if you take the X-ray, these are the characteristic features. What is it? Finding number one, you can see the end of the long bone is deviated laterally like this. This lateral deviation is what we call the splaying. Number two, the edges are very irregular. Can you see that the edges are very irregular? That is what is called as a fraying at the metaphysis. And third is the shape itself, which is curved like this. And this third finding is what we call the cupping. These are three characteristic features which will tell you or establish the diagnosis of rickets in a given child with some deformities. Okay, right. Now, this is a common topic of nutritional or vitamin D deficiency rickets. For your exams, you should also know one more topic in rickets, which is refractory rickets. These are not usual set of condition, relatively rare condition, but you have to know about the basic problems in all of these conditions. Okay, in refractory rickets, we have actually three categories. One category is defect in the vitamin D metabolism, called as vitamin D dependent rickets. Second one is called familial hypophosphatemic rickets. Both these conditions are inherited. Please remember, vitamin D dependent rickets is autosomal recessive mode of inheritance, whereas familial hypophosphatemic rickets is X-linked dominant mode of inheritance. These are two important one-liners which you should remember. And the third category is a miscellaneous category where we have CKD, that is chronic kidney disease, and renal tubular acidosis associated rickets. Okay. Now, in a given child, okay, conditions with refractory rickets cannot be diagnosed clinically. It would look like any other child with rickets. Then how will you make a diagnosis of refractory rickets? It's based on biochemical investigations only. So that is why this biochemical approach will be very, very helpful for you to solve any given clinical scenario of refractory rickets. We'll start with the first one, that is serum phosphate. The only condition where you have a high serum phosphate is CKD associated rickets, chronic kidney disease associated rickets, because in CKD there is a decreased excretion of phosphate. Decreased excretion of phosphate. That is why you get high phosphate in case of CKD associated rickets. Then the next one is the low phosphate category. There we have to do a ABG to look for acidosis. ABG to look for acidosis, and if acidosis is present, then of course it would be renal tubular acidosis. And if there is no acidosis, then we have to estimate the levels of PTH. High PTH is noted in VDDR. What is that? Vitamin D dependent rickets. And normal PTH is what is seen in familial hypophosphatemic rickets. This is the biochemical approach to rickets which you should make a note of. Okay, right. Then just short notes about other micronutrient deficiencies which are important for your exams. One is curving. The micronutrient deficiency is vitamin C deficiency. The characteristic features of this condition would include bleeding. Bleeds, correct? What are the bleeds you will look for? Gum bleeds, perifollicular bleeds, and third is subperiosteal bleeds. And this subperiosteal bleeds usually involve the limb region, and it will be categorized by a lot of pain. So you will see that the child will not even be moving the limbs also, but it is not a true paralysis. What do you call this? Pseudo paralysis. Pseudo paralysis. Okay, right. And the basic reason for this bleed is because of collagen defect in case of scurvy. Okay, right. Then the next one is acrodermatitis enteropathica, which is due to a severe form of zinc deficiency. Zinc deficiency. Actually, what happens is that there is a decreased zinc transport across the intestine. That is why there is a severe zinc deficiency. The characteristic features of this condition are two. One is diarrhea, which is a well-known association. Another one is a rash. And this rash is something which is characteristic. It is bilaterally symmetrical rash and usually involves the orifices. That's why it's called peri-orificial. So you will get this rash around the mouth opening, anal opening, all those things. That's why it's called peri-orificial rash. And xerophthalmia, I think all of you know about this. It's a vitamin A deficiency. Okay, and the characteristic features would include bited spots, which are the triangular spots, okay, in the bulba conjunctiva. Then we have keratomalacia, thinning of the cornea. It can also result in corneal scars also. These are the characteristic features of xerophthalmia. And very, very important in this section is you should know about the vitamin A dosage also. It depends on the age of the child. Less than 6-month-old child, it is 50,000 international units, which is recommended. 6 to 12 months, it is 1 lakh international units. And after 1 year, it should be 2 lakhs international units. However, you should also note one more thing, that if the age of the child is more than 1 year, but the weight is less than 8 kilogram, then you are supposed to use only 1 lakh international units. Okay, right? And the schedule for vitamin A treatment goes like this. Every day you have to give the same schedule, but as a 3-dose schedule, you have to give it on day 0, 1, and 14. Day 0 means on the day of admission. Day 1 is next day, and 14 is 2 weeks later you have to give. This is the schedule of vitamin A treatment, and with that will be the completion of micronutrient deficiency disorders in children.